Hi guys, today we're going to talk about the pharmacology of antifungal agents. Mycoses are just diseases that are caused by fungi. Mycoses or fungal infections are often chronic infections. So think about something like athlete's foot, right? This isn't something that comes and then a week later is gone. Right, this is infection that somebody typically deals with chronically for a long period of time. Compared to viruses or bacteria, fungi are frequently cutaneous. So fungal infections on the skin or cutaneous mycoses are much more common than, say, bacterial infections on the skin. And that's just because we have a lot of fungi that actually live on our skin to begin with. So if those overgrow, if we make conditions favorable where the fungus loves the conditions, they like the environment, then they'll overgrow. And all of a sudden we have a cutaneous mycosis or cutaneous infection. There can also be subcutaneous or systemic infections as well. It is possible for fungi to overgrow systemically in the bloodstream. We can have it in the brain for like meningitis, for example. So it is possible to have systemic disease as well. Fungi are resistant to antibiotics. Fungi are structurally different than bacteria. So the antibiotics that we have target features of the bacteria. Those same features are not present in the fungi. So antibiotics don't work for fungus. That's why we have separate agents. We have antifungal agents that treat fungal infections or fungal mycoses. The incidence of fungal infections is increasing, and this is for a couple different reasons. One, immune suppression. We treat a lot of diseases or prevent diseases by suppressing the immune system. For example, post-organ transplant, for autoimmune disease treatment. So to treat SLE, systemic lupus erythematosus, lupus. Or chemotherapy, right? When we're treating cancer, that attacks or destroys the immune system. So in all of those cases, the immune system is not functioning appropriately. Same thing with HIV. HIV is a virus that literally attacks the CD4 cells, the immune system cells. So it's associated with a depressed immune system. Both of these things allow fungi to overgrow and have infection. This is a big one here, is increased antibiotic use. When we look at the colonization of our skin, right? Our skin contains all different microorganisms that just live on us normally and don't cause problems. So on the skin, in the mouth, in the vagina, we have bacteria that live there all the time. And we have fungi that live there all the time, and they don't cause problems because they're in balance with each other. They constantly compete with each other for space, for nutrients, so they kind of keep each other in check. When we give an antibiotic to a patient, we kill bacteria. So now those bacteria drop out, and the fungi can grow like crazy. They now have all the space, they now have all the nutrients, and the fungi then grow to a point where there's an actual fungal infection present. So this is why overusing antibiotics is not good, right? This is associated with multiple different types of candida infections or yeast infections, right? We have vaginal yeast infections, oral yeast infections, which we call thrush. Sorry, my hair is driving me crazy. Both of those are associated with antibiotic use. So antibiotics should only be used when absolutely necessary. We don't give antibiotics for infections that are self-limiting or for viral infections. We don't give them just to make the patient feel like they're taking something. We only give them when indicated because they can lead to other infections like fungal infections. Here you just see the different types of fungi. So fungi can be divided into yeast, like Candida, which is the most common, Cryptococcus neoformans, and then Pneumocystis. I can never pronounce this. I'm not even going to try. Pneumocystis. Dimorphic, and which kind of have components from both yeast and mold. The molds include Aspergillus and then mucormycosis. So Aspergillus, mucormycosis, Pneumocystis, and Candida. So we'll start talking about the treatment of subcutaneous and systemic mycoses. So not skin infections, but actual systemic infections, which tend to be more serious. Amphotericin B, or Ampho-B, was frequently what we call it, is a very effective but very toxic antifungal agent. Amphotericin B works by binding to ergosterol in the plasma membrane of fungi, creating pores in the plasma membrane, which then allows things to leak out of the cell and disrupts the transmembrane potential, disrupts osmolarity, and kills the cell. If you look here, this is the plasma membrane of the fungal cell. And in this plasma membrane, again, it's got ergosterol. That's different from mammalian cells. Our cells, human cells, have cholesterol in the plasma membrane. So instead of, it doesn't target our cells like it targets the fungal cells because it's targeting ergosterol instead of cholesterol, which we have. But they're both lipid components in the plasma membrane. You can see here the Ampho-B coming in, creating a pore, and then, ions, molecules, stuff like potassium leaking out of the cell, and then cell death occurs. Amphotericin B has a very broad spectrum of activity. It's effective against most possible fungal infections. It's effective against most Candida, Aspergillus, Cryptococcus, Coccidioides, Blastomyces. It has a very broad spectrum of activity. However, we don't use it very frequently. And the reason for this is it has a toxic potential. Amphotericin B has the potential to be toxic, for example, renal toxicity, or toxic to the kidneys. So we only use it in, some like life-threatening infections. For example, invasive coccidioides meningitis. This is a very serious fungal meningitis that's not susceptible to many antifungal agents. So we would use Amphotericin B in this case. So use of Amphotericin B is really just reserved for infections that can't be treated by other antifungals. Kinetics, it's not oral, it's given parenterally. We administer Amphotericin B by slow IV infusion. Amphotericin B is a lipid, right? It's lipidy, so it's not water soluble. It's hydrophobic, which is why it can interact with the lipids in the plasma membrane. But because it's water insoluble, we have to do something to it so that it can go into the bloodstream. We need it to go into our bloodstream, so we need to do something to make it more water soluble. We can do that by adding components to it. We can have Amphotericin B that's formulated with sodium deoxylate, or we can have Amphotericin B that's formulated with lipids. So there's two different forms. There's the lipid-based Ampho-B, and then there's the sodium dex Amphotericin B. Now, the lipid formulation is best. The lipid formulation, what happens is the little lipids form lysosomes around the drug, and then they have like water-soluble components on the outside. So it forms little liposomes around each molecule of drug and allows the drug to go into solution in the bloodstream. The lipid-based Amphotericin B has less nephrotoxicity. It has much less nephrotoxicity than the sodium dex version. However, it's expensive. It can be like, $200 a day for therapy. So it's less nephrotoxic, but it's more expensive. So it's sometimes one or the other becomes more important in choice of therapy. Caution, the two different formulations are dosed differently. So that's important to keep in mind. You can't just flip from one to the other. Sorry. The sodium dex, I'm just off the top of my head. The sodium dex version, I believe, has less dose, like the dose is typically smaller, but I'm not sure. Just keep in mind the different formulations are dosed differently. So you can't just switch. If you say looked up the dose for the sodium dex version and then you were like, you know what, I want to get the lipid version. You can't just change the name. You need to go back and look at the dosing and make sure that you calculate the dosing appropriately. Amphotericin B is a narrow therapeutic index drug, which obviously, or you guys by now know, that means there's not very much difference between the therapeutic dose and the toxic dose. So you have to be very careful with dosing, because if you dose it wrong, you don't have very much wiggle room before you're getting into toxicities. So very careful with dosing. Fever and chills are common about 1 to 3 hours after the start of the infusion. Now, this is typically just the initial infusion. Usually it doesn't occur, every time you give it. It's usually just the first time you're giving it. There's a, almost like a flu-like reaction to it. Now you can prevent this or help this, decrease it by pre-medicating. So pre-medicate with a corticosteroid or antipyretic. So an antipyretic like acetaminophen, or corticosteroid like methylprednisolone or prednisone. If pre-medicate with these agents, then it's more tolerable. The patient doesn't have as bad of an experience with that first dose of Ampho-B. We mentioned that amphotericin B can be associated with renal impairment. So we'll see increased serum creatinine, decreased GFR and creatinine clearance. We can see azotemia, so like the patient not producing urine. Also, we see some electrolyte abnormalities. So we'll see decreased potassium, so hypokalemia, and decreased magnesium. So we'll see hypokalemia and hypomagnesemia as well. This typically improves after discontinuation of the drug. So frequently, or most frequently, it's not permanent damage to the kidneys. However, there can be residual damage with high doses of amphotericin B. So it is important to try and, again, make sure that your dose is being monitored closely. Strategies to try and lessen the renal impairment is one, use liposomal amphotericin B instead of the sodium dex version. Ensure adequate hydration. The more hydrated the patient is, the less likely they are to have renal impairment. So we can give infusions of normal saline prior to administration of the amphotericin B if needed to make sure that the patient is not dehydrated at all. Also, we can try and avoid other nephrotoxic agents. So, for example, drugs like vancomycin or aminoglycosides. Are also renal toxic. So you can avoid, combining multiple agents at the same time that are going to be hard on the kidneys. Amphotericin B also causes hypokalemia, which you just mentioned. We can see hypotension result as well. The hypotension occurs because of the hypokalemia. So hypokalemia, and then the hypotension is like a rapid drop in blood pressure. It's kind of like shock. It appears like it's a shock-like decrease in blood pressure. This requires potassium supplementation. So there's a lot of monitoring that goes along with the amphotericin B, right? And a lot of kind of therapy that goes along with using it, like other therapies. So, you give normal saline infusion beforehand. You give a corticosteroid or an antipyretic beforehand. Then you give this slow infusion of the amphotericin B. You need to monitor serum creatinine to make sure the kidneys are okay. You need to monitor the electrolytes to make sure that the potassium is okay, as well as the magnesium, but the potassium is the big one. You likely need to give potassium supplementation in order to prevent this huge drop in blood pressure. Also, be careful if the patient's on other drugs that affect potassium. So like digoxin, for example, right? If the patient's on digoxin, or if they're on a diuretic that causes hypokalemia, then you need to be careful, extra careful with the potassium level, or possibly stop those other agents if they can be stopped. Obviously, it's not easy to just stop digoxin. But if it's possible to stop or change the other agents, but really just be extra careful with potassium and make sure that you're supplementing it when needed. Thrombophlebitis is possible. Thrombophlebitis is alleviated by adding heparin to the infusion. So kind of overall, amphotericin B has a lot of toxicity. It's really challenging to give. However, it works well. So if it's necessary, if there's a life-threatening infection that you can't treat with something else, then you can treat it with amphotericin B. Give the liposomal form if possible. Pre-medicate with corticosteroids or an antipyretic. Pre-medicate with an infusion of normal saline. Administer potassium supplements if the patient becomes hypokalemic. When you're infusing the Ampho B, infuse it with heparin to prevent thrombophlebitis. Okay, that's a lot. Oh, also monitor serum electrolytes, monitor creatinine clearance, or serum creatinine, monitor serum creatinine. Flucidicine, or 5-FC. Flucidicine is an antimetabolite. It works by entering the fungal cell, and then once it's inside the cell, it gets converted to a series of compounds that disrupt protein synthesis. So it inhibits protein synthesis inside the cell. 5-FU is 5-fluorouracil. Fluorouracil is one of the components that it gets converted to. That's something that's a drug that we use for multiple different indications, including cancer. So this inhibits protein synthesis. We can use flucidicine plus itraconazole, which is another antifungal, for chromoblastomycosis. We also can combine flucidicine with amphotericin B for different types of systemic mycoses, and then for meningitis. Meningitis, obviously fungal meningitis, but meningitis that's caused by Cryptococcus neoformans, or neoformans, or Cryptococcus albicans. So the amphotericin B and the flucidicine kind of like work synergistically with each other, because the amphotericin B creates pores in the cell membrane. So the amphotericin B increases the permeability, and it allows the flucidazine to enter into the fungal cell easier. Flucidazine can be used for Candida UTI. So it is effective against Candida UTIs, urinary tract infections, but fluconazole is preferred. So fluconazole, which we'll talk about in a little bit, is actually preferred for Candida UTI. But flucidazine is also effective. So flucidazine penetrates fluids well, including the cerebrospinal fluid, including the CSF, which is why we can use it for meningitis. Penetrates the urine, which is why it can be used for UTI. Dose needs to be adjusted in renal dysfunction. Adverse drug effects, nausea, vomiting, and diarrhea are common. Severe enterocolitis is possible. So GI issues are kind of big issues with this because it can interfere with the lining of the GI tract. It can cause reversible neutropenia, thrombocytopenia, dose-related bone marrow suppression. So it's important to monitor CBC with differential to monitor blood cells. It can also cause some reversible hepatic dysfunction. So you might see elevated serum transaminases. So you can see elevated LFTs while the patient is on the flucidazine. But again, this is typically reversible. When the patient stops, liver function goes back to normal. The azoles, or the azole antifungals, are just antifungals that end in azole. So fluconazole, which is really commonly used, intraconazole, postaconazole, voroconazole, isovuconazole, right? They all end in azole. The azole antifungals actually include two different classes of antifungals, imidazoles and triazoles. The imidazoles are used topically. The triazoles are used systemically. So we're going to cover the triazoles here, and then the imidazoles, which are the creams that are used topically, we'll cover when we do skin infections, because we talk about them there again. The mechanism of action of the azoles is they inhibit a CYP enzyme to block the formation of ergosterol. Remember, we said that ergosterol is part of the plasma membrane in fungal cells. It functions just like cholesterol functions in our plasma membranes. So it blocks the formation of ergosterol, which disrupts the formation of the cell membrane, plasma membrane in the fungal cell. These were really effective initially, but resistance is now becoming a significant issue, especially among immunocompromised patients who are on prolonged therapy. So immunocompromised patients, as in patients with advanced HIV, patients who are post-organ transplant, they're frequently on chronic or prolonged antifungal therapy with an azole. So they will see that, over time, the fungus will develop resistance, which is obviously problematic. Drug interactions are really common with these antifungal agents. They act as CYP3A4 inhibitors, and you guys know that CYP3A4 is responsible for the metabolism of a lot of different drugs. So they do inhibit the metabolism of a lot of agents, which can lead to adverse drug effects. Many of these agents are also metabolized by CYP enzymes, so they can have drug interactions if they're taken with other inhibitors or inducers. The azoles are teratogenic, so typically avoid in pregnancy unless the benefit outweighs the risk. So unless there's some sort of, life-threatening infection that, there's nothing else for the mom to take, we typically avoid during pregnancy. So we'll talk in a little bit more detail about some of these, including fluconazole. Fluconazole is very frequently prescribed for yeast infections, candida infections, like a vaginal candidiasis. We see fluconazole used. It's highly active against Cryptococcus neoformans, and it's actually the drug of choice for Cryptococcus neoformans after induction. Induction therapy is with flucidicine and Amphotericin B. So we give flucidicine and Ampho B, and then we give fluconazole, and that's the fluconazole is a drug of choice for chronic treatment, or not chronic, but continued treatment for Cryptococcus neoformans. So it's highly active against Cryptococcus neoformans. It's also active against some species of Candida, which is more commonly seen. So that's what we typically see it prescribed for. Overall, though, fluconazole is really the least active of the azoles, so use is really limited to yeast infections. But again, yeast infections are really the most common, or some of the most common fungal infections that we're going to see. So we see it used a lot, even though it doesn't have very broad activity. We do see some resistance starting with some species of Candida, so that is important to keep in mind. We use fluconazole prophylactically post-bone marrow transplant. After bone marrow transplant, when we're giving a bunch of immunosuppressant agents, we're making it possible for fungal infections to bloom. So we give fluconazole prophylactically to try and prevent that. We already mentioned Cryptococcus neoformans. Fluconazole is effective against most mucocutaneous candidiasis. So most candida infections that are in like the mucous membranes. So mucous membranes as in like in the mouth, or mucous membranes in the vagina. Fluconazole is very commonly used for vulvovaginal candidiasis. For vulvovaginal candidiasis, we just give one single dose. It's just one dose of, I believe it's 150 milligrams of fluconazole, and that's it. So one dose and done. It's really easy to prescribe in that situation. You frequently will see patients get prescribed an antibiotic, and then shortly after they'll be prescribed fluconazole, which obviously the antibiotic caused the vulvovaginal yeast infection or candidiasis, and then the fluconazole is for that. The most common adverse drug effects are nausea and vomiting, headache, and rashes. It is cleared renally, so the dose needs to be adjusted in renal dysfunction. Itraconazole is a more broad spectrum azole antifungal. Itraconazole is the drug of choice for blastomycosis, sporotrichosis, paracoccidioidomycosis, that's a mouthful, paracoccidioidomycosis, and histoplasmosis. Itraconazole is rarely used for Candida or Aspergillus. There are just other agents that are preferred in both of those cases, but it is relatively broad spectrum. Adverse drug effects include nausea and vomiting, rash, which we really see with a lot of the azoles, hypokalemia, hypertension, edema, headache, are all possible. Liver toxicity is possible, especially when used with other hepatotoxic drugs. So it's important to see what else the patient is on to see if you're going to have an issue with the liver. It does have a negative inotropic effect. So the negative inotropic effect is important to keep in mind with heart failure. So it should be avoided. Avoid in patients with heart failure or evidence of ventricular dysfunction. Just kind of FYI in taking it, it's by mouth. There's a capsule and a tablet, and they should be taken with food or some acidic drink. The solution should be taken on an empty stomach. So it's kind of odd that the capsule and tablet are taken differently than the solution, but they're opposites. So that is, something to keep in the back of your mind. Solutions on an empty stomach, capsule and tablet are taken with food and an acidic drink. And I'm honestly not sure how it causes hypertension. It does seem odd that it causes hypertension while having a negative inotropic effect. You would think that the negative inotropic effect would lead to hypotension. But it does have both. It is it's clearly shown in cases that it can be associated with a negative inotropic effect in the causing a congestive heart failure and edema, and then also hypertension and hypokalemia. So. Postaconazole is another broad-spectrum antifungal agent. It's used in the treatment and prophylaxis of invasive Candida and Aspergillus in severely immunocompromised patients. Also used in treatment of other various invasive infections, so like systemic infections caused by multiple different types of fungi. It's interesting, all of the other azoles are metabolized by CYP enzymes. Postaconazole is not. Postaconazole is still metabolized in the liver, so it's still processed in the liver, but it's glucuronidated as opposed to being metabolized by CYP enzymes. So if you have a patient where you're having where they're on something that's an inhibitor or an inducer of a CYP enzyme and you want to try and avoid that interaction, you could try, postaconazole. Absorption is decreased with an increased gastric pH. So if the stomach is not acidic enough, if the pH goes up into, less acidic pH, then the absorption of postaconazole will not be as good. So use is contraindicated with PPIs, proton pump inhibitors. So like omeprazole, for example, use is contraindicated with that. Postaconazole is a potent inhibitor of CYP3A4. So use is also contraindicated with many agents that are metabolized by CYP3A4. So things like contraindicated with drugs like atorvastatin. Citalopram is atorvastatin is a statin for cholesterol. Citalopram is an SSRI for depression and multiple other mental health issues. Same thing with risperidone. Risperidone is a mental health drug. Risperidone, and there are numerous. So just kind of keep in mind, you don't need to memorize necessarily the whole list of drugs, but keep in mind that there are drug interactions with drugs that are metabolized by CYP3A4. So that's something to look out for. Voroconazole is another broad spectrum agent. Voroconazole is a drug of choice for invasive aspergillus. It's replaced Amphotericin B for aspergillus because it's generally better tolerated than Amphotericin B. It's also used in the treatment of invasive candidiasis and other serious infections caused by Pseudosporium or Fusarium. One of the most important things to keep in mind with voroconazole is drug interactions. There are numerous clinically important drug interactions. Use with many drugs is contraindicated. So like use with rifampin or rifabutin, use with carbamazepine, use with St. John's wort, which is actually over the counter. Patients frequently use this. This is an herb over the counter that patients use for depression. So that's important to make sure you're talking to the patient about because they can do that without you knowing. Use is contraindicated with any of these agents and more. Voroconazole is extensively metabolized by CYP2C9, 2C19, and 3A4, and it exhibits nonlinear kinetics. So it's not, linear kinetics is like when you increase the dose, you increase the concentration in a nice fashion. This is nonlinear. So it's harder to predict what change in dose or change in metabolism is going to do to the concentration of the drug. Also remember, patients exhibit 2C19 polymorphisms. Patients could be rapid metabolizers or slow metabolizers, and that can affect concentration of the drug. And then finally, voroconazole is a CYP inhibitor itself. Voroconazole inhibits multiple CYP enzymes. So voroconazole is very challenging as far as drug interactions go. It has a very similar spectrum of activity to postaconazole though. So voroconazole and postaconazole have very close spectrums. They can be used for very similar things. But postaconazole is not metabolized by CYP enzymes, so you don't have an issue there. And it only inhibits 3A4. So, depending on the patient, drug interactions may be the thing that controls your choice of agent if you're choosing between voroconazole or postaconazole. High troughs, which, like when you're looking at the drug concentration, the peak is the high point, the trough is the low point. So high troughs, meaning the concentration never drops really low, can be associated with visual and auditory hallucinations and increased hepatotoxicity. So with voroconazole, you really don't want the drug to stay high. You want your dose to decrease some and then to go up, your dose to decrease. So you don't dose it too close together, in other words, because it is associated with, increased likelihood of adverse drug effects. I don't have a separate slide for isobuconazole. Isobuconazole is really similar in spectrum and similar in use to voroconazole and postaconazole. The equinocandins include capsofungin, mycofungin, and inigilafungin. These agents have very potent activity against aspergillus and candida. They're even active against the strains that are resistant to the azoles. So you can have, really resistant aspergillus or really resistant candida, and the echinocandins are still active against it, but they're not active against other fungi. So they have very strong activity, but pretty narrow activity. So capsofungin is first line for invasive candidiasis, including candidemia. So when there's candida in the bloodstream. It's second line for invasive aspergillus. So this would be aspergillus that has either failed or can't take the azoles or amphotericin B. So for invasive aspergillus, azoles would be, first choice, but if they can't take the azoles or ampho B, then capsofungin would be the choice that you would use. Capsofungin dose needs to be adjusted in moderate hepatic dysfunction. Caution with CYP inducers because you'll have drug metabolized quickly. Also, it's contraindicated with cyclosporin. When capsofungin is given with cyclosporin, there's a high incidence of elevated hepatic transaminases. So given with cyclosporin, it increases hepatic dysfunction. So it increases the likelihood of increased LFTs and hepatic issues. Micafungin and inidilafungin are also first-line agents for invasive candidiasis, including candidemia. So they're all first-line agents for invasive candidiasis. Micafungin can be used for prophylaxis in patients who are undergoing stem cell transplants. And neither of these agents are CYP substrates. So there are no associated drug interactions. So again, the drug interactions could be something that guides your choice of therapy. If you were treating candidemia or some invasive candidiasis and you had to choose one of these agents, if the patient was on cyclosporin or the patient was on something that was a CYP inducer, then you would want to give micafungin or inidilafungin instead. Administration of the equinocandins is by slow IV infusion. The slow infusion is to avoid histamine-like reactions and flushing. So if it's given too fast, the patient gets, again, just like a histamine-like reaction, almost like an allergic type reaction and extreme flushing that's not pleasant. They're given once daily. A loading dose is required except for micafungin. So the other agents, capsofungin and inidilafungin, require a loading dose. Adverse drug effects include fever, rash, nausea, and phlebitis at the infusion site. Terbinafine, naphthafine, and butanafine are the squalene epoxidase inhibitors. I have terbinafine bolded because terbinafine is the agent that's available in an oral tablet that is most effective, or the only really effective agent for some situations or infections in certain areas like the nail or the scalp. These drugs work by blocking the biosynthesis of ergosterol, right? So ergosterol's really been the target thus far for most of these antifungal agents. Spectrum of activity is against trichophytin, that's it, so pretty narrow. The oral terbinafine is the drug of choice for dermatophyte onychomycosis, so that's the nail fungus, right? When someone's nails are, turn colored and have this fungal infection on them. Also, oral is used for tinea capitis, so infection in the scalp. Now, they make, nail polishes that you can put on for the onychomycosis, but they don't really work, and the patient has to use them forever, for a really, really long period of time. Even oral therapy requires 3 months of therapy. So that's 3 months that the patient has to be taking the oral terbinafine in order for this to be effective. So it's a lot of the over-the-counter stuff that you would paint on the nail. It's just really not effective. Not because if you think about it, the infection's like in the nail bed underneath the nail. So you need something to be able to get into the bloodstream to really get to that area. It's hard to put something on the top of the nail and have it penetrate down into that area. Topical agents, though, can be used for tinea pedis, right? So like athlete's foot is what people call that. Tinea corporis, tinea cruris, and tinea versicolor. In general, itraconazole or griseofulvin, they've also been used before for nail fungus, but the terbinafine is just much better tolerated. It's better tolerated, it's got a shorter duration, so it's preferred. Also for tinea capitis, oral is required. You have to use oral therapy, not topical therapy. Topical therapy, though, for like athlete's foot or jock itch, topical therapy is typically for 1 week. Terbinafine is, it has a super long half-life. The half-life of the drug is like hundreds of hours, like 200, 300, 400 hours. What happens is it gets deposited in the tissues, it gets deposited in the nail, in the skin, adipose tissue, and then it gets slowly released. So the half-life is really long. It's extensively metabolized by CYP enzymes, and it's cleared by the kidneys, excreted in the urine. So it should be avoided in renal or hepatic dysfunction or impairment. Terbinafine is also an inhibitor of CYP2D6, so it's important to keep in mind. Adverse drug effects: nausea, diarrhea, dyspepsia, headache, rash, kind of general stuff. There can be taste disturbances and disturbances with vision as well. And then elevated hepatic transaminases. So that was terbinafine, right? Which is the oral formulation, which is just much more effective. And there's also a cream. I mean, there's a cream for terbinafine as well that we can use for like the feet or sorry, I'm thinking, all I keep thinking is jock itch. But anyways, terbinafine is a pill and a cream. The naphthafine and butenafine are only topical. So we can use them topically for tinea corporis, tinea cruris, tinea pedis. And these we typically use for 2 to 4 weeks, but they don't come orally. So we don't use them for the nail, we don't use them for tinea capitis, we don't use them for the scalp, because we don't have an oral formulation. Also notice the length of therapy is different. The terbinafine we just use for 1 week. The naphthafine and butenafine we have to use for 2 to 4 weeks. Nystatin. Nystatin comes in a couple of different formulations. There's nystatin topical, like cream and ointment. There's also a nystatin suspension that is given orally. So nystatin is used for cutaneous and oral candida infections. So oral yeast infection, like when somebody has thrush, we give nystatin. And then again, obviously cutaneous candida infections, we would give the cream. The mechanism of action of nystatin is similar to amphotericin B. It works similarly to amphotericin B. But when we use it cutaneously, and even when we take it orally, it is negligibly absorbed from the GI tract. So we don't get very much systemic absorption from it, and this is why we don't use it for systemic diseases. And then also, it's not given parenterally because of toxicities. So we only use it topically. It can be given orally, but again, it's not actually being absorbed from the GI tract. So we avoid the systemic adverse drug effects. when we give the oral formulation, so again, this is a suspension, we say swish and spit or swish and swallow. So they can swish it around their mouth and spit it out for oral thrush, or swish and then swallow if it's oral pharyngeal as well. Again, for oral pharyngeal candidiasis or thrush. This happens sometimes when we give antibiotics, for example. We also see this frequently in patients who are immunocompromised. It can be given vaginally for a vulvovaginal candidiasis as well. And then topically, just the cream for cutaneous candidiasis. The imidazoles, we said are topical azoles, right? We said when we talk about the cutaneous mycoses, we would talk about the imidazoles. We already talked about some of the azoles. We talked about the azoles that are taken orally, like fluconazole, postaconazole, voroconazole. The imidazoles are, again, the topical azoles that we use for skin infections. There are a bunch of them. You'll see them at the bottom. Clotrimazole is common. Equinocandins, ketoconazole is also common. Miconazole, teoconazole, sulconazole. They have a very wide range of activity. They are used for tinea corporis, tinea cruris, and tinea pedis. So just like we saw with the other creams, they can be used for jock itch or athlete's foot. They can also be used for oropharyngeal candidiasis and vulvovaginal candidiasis. Clotrimazole comes in a troche, and miconazole comes in a buccal tablet for thrush. So like the clotrimazole troche, it's kind of like a lozenge. You just let it dissolve in the mouth and the drug slowly gets dissolved into that area. And then the miconazole buccal tablet, you just place in the cheek and it slowly dissolves. The others come in creams. Ketoconazole does come in a tablet, but it's very rarely used. The ketoconazole, when taken systemically, causes severe hepatic injury. It can also cause adrenal insufficiency. It has a bunch of drug interactions. It's just kind of a nasty drug when it's taken by mouth. But we can use it topically and it's fine. It also comes in a shampoo. Comes in a shampoo and it comes in a cream. Adverse drug effects include just irritation to the skin, so contact dermatitis and some swelling or edema. If used for vulvovaginal candidiasis, we can see some irritation to the vulva. Efinaconazole and tavaborole are topical agents that are used for toenail yeast infections. They have to be used for 48 weeks, which is almost a year. That's a very, very long time, and they still don't have great efficacy. So this is why we use the oral agents, the terbinafine oral, for nail infections. Cyclopirox is active against a wide range of fungi. It comes in multiple different versions. It comes in a shampoo for seborrheic dermatitis. It also comes in a cream, topical agents that can be used for tinea pedis, tinea corporis, tinea cruris, versicolor, and cutaneous candidiasis. Again, has to be used for 48 weeks. So a lot of the other agents that are used for shorter periods of time would be preferred. Tolnaftate is comes in multiple versions, right? Solution, cream, powder. It's not effective against any candida, so it's not effective against yeast. But we do see it effective in some tinea pedis, tinea cruris, and tinea corporis. The tolnaphthate is over the counter. That's just like Tinactin, I believe is the brand name. I'm not sure if that's correct, but it's an over-the-counter agent. All right, that's it, guys. We made it through all of the antifungals in about an hour, so I will stop there.